At the heart of what we do is exploring limitless possibilities to enrich lives all over the world. Life is precious, and we are in the business of cherishing every precious heartbeat. Every day brings a new reason to better our lives. Something to learn, something to laugh and enjoy, something to dream. For as long as there's a dream, there's hope, and as long as there's hope, there's joy in living. Reasons for us to keep every heart happy and healthy. Helping us in our endeavor are the many interventional cardiovascular solutions that we create. At our state-of-the-art facilities, we make our stents and catheters, wires and needles, German excellence and Indian innovation backed by credible research. With the unmatched advantage of being the only company with clinical trials data spanning over 10 years for efficacy and safety. And a one-of-its-kind partnership with the German Heart Center, renowned for its pioneering advancements in cardiovascular technologies. It's not surprising we have over 5,000 satisfied clients and 1 million smiling patients in over 50 countries around the world. We trust good things happen when you follow your heart, because there's an ocean of opportunities to discover. And our journey has just begun. Translumina, exploring limitless possibilities of life.
All right. So over to you, George, followed by Dr. Mendes. The podium is all yours. Thank you.
Yes, just one moment, please. Is it visible?
Yes, yes. Please make it full screen.
It is full screen on my screen. Is it okay?
Yeah,
Yes.
yeah. Perfect. Please go ahead.
So, good morning, everybody. I say good morning because in Argentina it's morning. So in Europe and the rest of the world, it's an afternoon. Thank you, all gentlemen and doctors, for being here. So this is a small presentation, a very brief one about our company and activities. Allow me to start. You may have heard, of course, the name of the professors. Absolutely, you know that this is a company that started in the year 2000. Today we have a presence in over 50 countries. We have various awards. We have 3 different manufacturing facilities in Germany and India. We have the longest clinical data products with the Yugon family of products and the Vivoisa. Of course, the products are CE certified and quite a few in the pipeline, while we have achieved the milestone of over 1 million implants. As you may know, the company started in the year 2000. It's a global interventional cardiology devices company. Of course, we are fully integrated, and we have had also strategic partnerships with top manufacturers and suppliers all over the world. And our facilities have started and still are in Germany. However, we have extended the facilities in India. We have an even bigger factory. We have also products that are both in Indian and German facilities. Some of them are also produced, and they are expecting the CE mark. And as you may know, we have a very, very long collaboration with the German Heart Center. The German Heart Center has been the first cardiology clinic, I think also the oldest in Europe. Its foundation was actually 50 years ago. We are very proud to be with them, and absolutely, of course, with Professor Castrati. And of course, all the papers and publications have been in top magazines like GACC, Circulation, and the European Heart Journal. Looking back a little bit in the past of the company, as I said, we started in the year 2000, and we were one of the first companies that started with drug-eluting stents. Actually, Translumina Therapeutics and Translumina in Germany have been in partnership, first as a distributor in the year 2010. In 2015, still after 7 years, we have a very good collaboration with Asahi Intech. We are representing them in India, where we have also a #2 position. And we started also manufacturing vascular accessories in the year 2016. Multiple also companies like Kaneka Balloons, Impella miniature heart pumps. So all these strategic partnerships gives us the capability to boast that we do not have just drug-eluting stents and balloons and stents, but also a full portfolio. Latest innovation in our portfolio, partnership was the Shockwave IVL. So we are representing again this very unique product in the country of India. As for the products, already you know them, you have used them. The majority of the doctors, we have the Yukon family with a biodegradable polymer, cobalt chrome, stainless steel also versions for calcified lesions. Of course, we have the latest Vivo Easer, which is also available in Argentina, and we have very good feedback from the doctors. And absolutely, of course, we also produce cobalt chromium bare metal stents, as well as balloons, semi-compliant balloons that are, of course, CE marked. As I said in the previous slides, we are the world's first and only company to have the drug-eluting stent with a 10-year safety and efficacy. And now this is enjoyed from both our Yukon Choice and the Vivo Easer drug-eluting stent. For this, we have received, of course, global certification by the American Heart Association and the European Society of Cardiology, and all the papers and publications are available for both doctors, nursing staff, and all scientists around the matter. As I said, due to the big investments that are being done in Translumina, we have a very interesting pipeline of products with, let's say, more well-known like high-pressure balloons, guide wires, thrombosuction devices, but also more elaborate that will come in the coming years, like transcatheter tricuspid valves, miniature heart pumps, TAVI, drug-eluting balloons. And as we said in the beginning, we have a complete list of balloon catheters, semi-non-compliant balloons, also working on some peripheral and scoring balloons, either directly or with via strategic partnership, and ultra high-pressure balloons. A few words about the leadership teams. Mr. Gurmeet Singh and Mrs. Punita Arora are the founding members. Latest insert in our management team is our new group CEO, Mr. Indranil, and of course our new managing director and chief operating officer in Germany, Mr. Armin Kisser. I'm sorry for the presentation going back and forth, but this is a timed presentation, so I have to move back. What is more important to say also about the users, we have the Translumina website and of course applications. So we also kindly ask the doctors to download this Trans Academy app that actually contains almost everything. I mean, the case studies, your case studies, the products, their features and benefits, publications, product brochures, new events, whatever it is. This is very important, and actually with the touch of a button, you could have everything in your mobile instead of going through brochures or whatever it is. So if you haven't already, please be so kind and download the Trans Academy app. So this was the last slide. Thank you all for your being here, and of course, I give the floor now to Dr. Oscar Mendes, who is our moderator. Thank you very much.
Okay. Thank you so much, George, for your presentation. Thank you for the invitation. I'm Oscar Mendes from Favaloro Foundation in Buenos Aires, Argentina. And now is the time to introduce our chairperson, who is Professor Adnan Castrati. He actually doesn't need any kind of presentation, but just to remember, he is the head of department of the German Heart Center in Munich, and he is the chief physician and deputy director of the cardiovascular disease. We also have an expert panel here. We have Dr. Ruber Piraino, who is Director of Interventional Cardiology at Sanatorio Delta in Rosario, Argentina. He was also president of CASI. Dr. Jorge Baccaro, Chief of Cardiology and Interventional Radiology at Cardiovascular Institute in Corrientes, Argentina. Dr. Alejandro Cherro, he's the Director of Interventional Cardiology career, all together with the CASI and Buenos Aires University. Dr. Alejandro Palacio, he is an interventional cardiologist, past president from CASI too. And Dr. Martin Cisneros, who is the head of hemodynamic service at the French Sanatorio in Cordoba, Argentina, and he is the current president of CASI. With this tremendous expert panel, I will ask Dr. Adnan Castrati to start with the first presentation. The title is Importance of Clinical Trials, 10 years data of safety, efficacy in a diabetic patient subset of population polymer-free DES. Thank you, Dr. Castrati. We are hearing you.
Thank you, Oscar. Thank you very much for your kind introduction of our center, of me also. So I'm very happy to be with you and to share with you some thoughts about this important stents. So I'm not sure since when you have been in contact with the two stents of Translumina, but just I wanted to highlight during my presentation here that there is a lot of work behind these two stent platforms that you are using now in Argentina. So we have a 20-year experience with them. We started with working with bare metal stents first, improving the stent platform, and then we went on with in vitro data, with animal data, with first-in-man studies, and with pivotal trials. And what we have done is there are the first 10-year clinical studies with second-generation drug-eluting stents. There are no others. There are some 10-year data, but only for first-generation drug-eluting stents. So I would start with the limitation of the first-generation drug-eluting stents, and the main limitation. There are also drug-related limitations, such as the paclitaxel with Taxus, but I would say that for both Taxus and Cypher, the limitation was first the thick struts. You see here that the 132 micron and 140, which is very high in comparison with today's stents. Why thick struts were negative? Because it was shown here. I have shown the data from the ISAR stereo trial, circulation 2001, and you see the effect of thick struts on restenosis, both angiographic and clinical restenosis. We have compared here two very similar stents, multi-link, do it with the multi-link classic, the first multi-link with 50 micron, and here 140. So there is a big difference in strat thickness between them. 651 patients were randomized between the two, and you see the results: angiographic restenosis with a thin strat stent with this 50 micron was 15% versus 25.6, 26% with the thick strat stent. Also, target vessel revascularization was significantly reduced by reducing the strat thickness, and that's why the strat thickness used for Taxus and Cypher was not compatible with these results. The second limitation, main limitation, I would say, is a poor biocompatibility of many permanent polymers, including those used for Taxus and Cypher. And here are the data from one study, 2004. It was published 2004. That means only 2 years after the first publication, the Ravel publication in New England Journal of Medicine, 2002, and in middle of a big enthusiasm about the drug-eluting stents, the group of Virmani showed that the perfect polymer remains unknown, and all polymers in use today induce some degree of inflammation, as shown on the right side here. You see the great inflammation around the stent straps. That's why our focus at the time was just to realize the drug-eluting stents that was free of this limitation. That means with stent straps and also with drug on it, but without polymer. So we started, as I said before, we started by improving the stent platform. And here are the two studies, Easier Stereo, I have already mentioned it, and Easier Stereo 2, it was in the same line with Easier Stereo 1, showing both that irrespective of the stent type used, the thin strat stent was much better in terms of outcomes as compared to the thick strat stent. And after these two publications here, you know that the standard strat thickness now is much less than that used with Taxus and Cypher. The second progress made with the stent platform was the movement from polish to microporous stent surface. We have used the data from the group of Palmas that showed in vitro that the rough surface improves endothelialization, and you see here that the size of the microporous was associated with greater endothelialization of the struts. That means that endothelial cells, for endothelial cell is more advantageous to have thick struts as compared to thin struts. But not only the endothelialization was improved by the rough surface, also the neointimal proliferation was also reduced with the area of pores. That means that more porous struts were associated with less neointimal proliferation. This all was in vitro in preclinical data. We used this data just to test the hypothesis that microporous strat surface was not bad, was even better than the Polish surface. And we launched this small study with 200 patients. You see the stents used in this study, the same stent architecture, but the difference was just in the microstructured surface in one side and the Polish surface on the other one. These 200 patients were evaluated in terms of angiographic restenosis, and you see that even for these 200 patients, which the number is small, relatively small in comparison with big trials, but you see a big difference in restenosis, angiographic restenosis, 25% as compared to 35% with the Polish surface. That means this confirmed the data, the in vitro data with the microporous surface. In all these 200 patients, there was no patient with stent thrombosis. We couldn't go further on because we were much more attracted by the development of drug-eluting stent technology, but we knew that this microporous surface has also another advantage, not mentioned in the in vitro studies. It increases the capacity, the drug capacity of the stent, and also it slows down the release kinetics, because just imagine the substance in these micropores needs more time to go out, and that is one reason why it was used also for drug-eluting stent technology. So, and with this data, we went to the in vitro studies, release kinetic study, using two kinds of stents, the micropore stent and the cipher stent as a control. And you see the difference. Although it was slowed down in comparison with the other surface of the stents, but it was not enough, because you see that the blue line here was much faster than the cipher stent. That means it was a release kinetics that probably was not appropriate for clinical use. We have done a lot of studies also with without polymer at the time. The results were good, but not as good as those achieved by permanent polymer-based drug-eluting stents. That's why our next focus was how to slow down the release kinetics of this micropore stent with sirolimus without the use of polymer. We went through different substances to see what is the combination that would improve the results of the polymer-free drug-eluting stents developed in our center. And we've identified Propofol as one of the best candidates, because Propofol has two properties. One, it is the only study in New England Journal of Medicine, published in 1997, that showed that an oral treatment with Propofol was able to reduce restenosis. There is no definitive study for oral administration of drugs that shows an effect on restenosis, and this was the first and probably the only one showing an effect. But on the other side, the second positive property of Propofol is that it is highly lipophilic. And with its lipophilicity, it is able to slow down the release kinetics of the limus drug used in stent platforms. That's why Vivo-Isar, which you are now becoming familiar with it, it's a unique polymer-free. It's not a usual, normal polymer-free drug-eluting stent, because it is not only polymer-free, but has a dual drug combination for elution, sirolimus plus Propofol. Here are the data of the release kinetics of the drugs. And if we take as a control sirolimus released from a biodegradable polymer-based drug-eluting stents here, you see that both sirolimus and Propofol in this polymer-free stent platform is released with the same velocity as that achieved by the sirolimus coming from the biodegradable polymer-based drug-eluting stent. Here are the animal data. We have a lot of histology data showing that on the right side here, this dual drug-eluting stents without polymer is associated with very high endothelialization rate and very low inflammation, very comparable to the bare matter stents, and also lower fibrin deposition as compared with that seen with biodegradable polymer-based drug-eluting stents. After doing some smaller study with up to 1,000 patients, we carried out the largest at the time, the largest clinical study comparison between two second-generation drug-eluting stents. On one side, you see the Vivo-Isar drug-eluting stents with 2,002 patients, and on the other side, it was the standard stent used in our cath lab, sotavirmus eluting stent. It was the Resolute stent from Medtronic. You see the numbers also, 2,002 in one and 1,000 in the other group. Our primary endpoint was at 1 year. We recorded all the MACE events at 1 year, but also it is very, very valuable for this study to provide angiographic follow-up data for more than 3,000 patients. This is for sure worldwide the largest follow-up angiographic study done ever with drug-eluting stents. And you see here that there is no difference in late lumen loss between the Resolute and the Vivo-Isar DES study, Vivo-Isar drug-eluting stent. But you know that our intention was to achieve better, safer, long-term results. But it was a good promise that here to see that by removing the polymer, you don't compromise the angiographic results within 1 year. As I said in the beginning, this is one of the 2 studies with 10-year data for second-generation drug-eluting stents. Here, both stents are compared at 10 years, and you don't see any difference at 10 years for the primary endpoint. It was a device-oriented clinical endpoint. And on the other side, we have very low stent thrombosis rate up to 10 years, both of the stents, but numerically a little bit better for the Vivo ESAR, are below 2% at 10 years. Let's see now the studies, the randomized clinical trials with 10-year follow-up. I said at the beginning that there are some studies with 10-year data, but they are related to first-generation drug-eluting stents. Here we have the CERTAX trial. The CERTAX trial was the first trial that compared in all comers Taxus with Cypher. And you see the combined rate of definite stent thrombosis for Taxus and Cypher. It is about 6% at 10 years. Here we have the data from the SORT-OUT 2 trial, which compared the same Cypher and Taxus. And the 10-year data showed an even higher stent thrombosis rate, more than 8% at 10 years. And here are the data for the Vivo ESAR, a stent thrombosis rate at 10 years below 2%. But everyone may say that this is a comparison. It's not a fair comparison because we know that the first generation drug-eluting stents were associated with a higher stent thrombosis rate. That's why I just put here also the data from the ESAR test 4 for the Xias. You know that the Xias is already now a worldwide standard of second generation drug-eluting stents. And here you see that the number of stent thrombosis was numerically lower for Vivo ESAR, although it is also good for the Xias stent below about 3% at 10 years. If we put here just more recent data with polymer-free drug-eluting stents, you know that BioFreedom uses the same microporous stent platform as that used in Vivo ESAR, but without any other substance. So it is only the drug, the antiproliferative drug on it. And the data published in New England shows that the stent thrombosis rate at 1 year with this stent platform is about 2%. Just compare 2%, less than 2% up to 10 years for the Vivo ESAR, and more than 2% at 1 year for the BioFreedom. You see here the difference made by adding the substance, the Probocon drug, on this dual drug-eluting stent. I'd also highlight here 2 subgroups for which the Vivo ESAR might be specifically beneficial. Here, the calcified lesions. You know, everyone who is active in the cath lab knows that calcified lesions are associated with a higher adverse event rate as compared to non-calcified lesions. And here are the data from almost 5,000 patients treated in our center with second generation drug-eluting stent in the settings of ESAR test 4 and ESAR test 5. Myocardial infarction rate up to 10 years was much higher for calcified lesions as compared with non-calcified lesions. And exactly for these high-risk lesions, the Vivo ESAR stent was associated with a reduction in the rate of myocardial infarction as compared to those who were based on the permanent polymer. Another subgroup that attracted our interest and our attention was the subgroup of diabetic patients. Here are the 10-year data from the ESAR test 5 trial, and you see we have almost 600 diabetic patients with the Vivo ESAR and almost 300 diabetic patients with the Resolute stent. 10-year data, no surprise at all, the diabetic patients have a higher MACE rate at 10 years. You see the 2 curves here and the curves for non-diabetic patients. But what is interesting here, for non-diabetic patients, there was no difference between the Vivo-ESAR and the Resolute stent, and there was a difference for diabetic patients. That's exactly for this high-risk subgroup of patients. The elimination or the avoidance of the polymer and the combination of sirolimus plus propofol is associated with a reduction in the MACE rate up to 10 years. But not only the MACE rate, more importantly, the all-cause mortality was also reduced, although numerically, because statistically you need more patients probably, but this is almost significant with 0.1, with a reduction of 16% of all-cause mortality with the use of Vivo-ESAR stent. And you see that for non-diabetic patients, the same as for MACE, there was no difference between polymer-based drug-eluting stents and polymer-free drug-eluting stents. Thank you very much for your attention.
Thank you so much, Dr. Anand, for your excellent presentation. May I ask the panel for some questions or comments to Dr. Castrati? Okay, meanwhile, I have one. Do you believe that the propofol is acting as regulating the kinetic release of the sirolimus, or is an additional effect of the drug itself?
I would say both, because so the data from release kinetics, we have very clear data that propofol is slowing down. That it's not difficult to measure the release kinetics, and it was done before starting the human studies in our center. This is a clear thing. The other thing, whether propofol is also adding an anti-proliferative or anti-inflammatory effect. Propofol is antioxidant. And so it is theoretically, it is well possible and supported also by this study I have shown in New England, which is the only study I said, but it was only with balloon angioplasty, not with stents at the time, because it was earlier. So I think that there are good data to support a combined effect in release kinetics and anti-proliferative and anti-inflammatory effect.
Great, thank you. So if we don't have any additional comment, maybe we can move on with the rest of the speakers.
Oscar, may I say something? Because at
yes.
4 or 12 your time, I have to leave because we have a very important meeting here.
Oh, okay, I understand. I fully understand. One very short question before you leave in. Do you believe there is a place to test this stent in a high bleeding risk patient with a very short dual antiplatelet therapy?
Sure. It's a place because you know that there are several studies now trying to shorten the dual antiplatelet therapy duration, and also those polymer-free, for example, Pyofreedom was used in those subsets of patients. But with this, without polymer, I am sure that you don't need a longer than 1 month therapy. But we have to show it, because at the beginning, 10 years ago, when we started, or more than 10 years ago, when we performed this trial, so it was for drug-eluting stents, it was needed a longer than 1 year therapy at the time. So we didn't have the courage to go shorter at the time.
Yeah,
but
I know.
Yeah.
Okay, thank you so much. Let's move on. Now I will ask Dr. Carlos Fernandez Pereira. He is interventional cardiology for Sanatorio Otamendi here in Buenos Aires. Carlos is going to present a very complex case. Carlos?
Okay, thanks, Oscar, and to all the panel. Thanks for the invitation. Can you see my screen?
Yes.
Okay, this is
Go ahead.
Latest main case with intracoronary image. And this is a 73 years old male. He's a colleague, a physician, internal medicine, overweight, and he entered to a hospital because of dyspnea and currently usually type 3 functional class, but sometimes with dyspnea on rest. And no changes in the EKG, but although he has some changes in V1 to V3 and negative T T1, T2, so in the inferior wall, and no troponin at the admission, but we have some kind of anterior hypokinesia, so the diagnosis was unstable angina. So he was a previous smoker and stressed, and he has a lot of his familiar history of coronary disease with hypertension and cholesterol, and previous also PCI in 2004 to LAD, in 2018 because of acute myocardial infarction. And this is an important point to see later about this, especially to see what happened to LAD. The usual medication, he never stopped the antiplatelet therapy and all the other treatment. And so we decided to study him because of the very heavy prior history. And we see the other films, and we always see this plaque with no other changes. We never touched that plaque before, and it's still the same plaque image, so we didn't touch at this time also. But at the left main, we have this image at the bifurcation, especially in the ostial lesion of LAD, and the left circumflex, and in a lateral branch of the circumflex. So we have this very impressive disease in the ostial lesion and involving the left main bifurcation and the left circumflex. So this time, since this patient strongly refused the surgery, so we really don't have any other chance to treat him, at least at this time. And the other thing is to treat also the left circumflex and the lateral branch. But the LAD, as you can see, although he has some hyperplasia of the LAD previously treated, this is not really a restenosis. So the main thing for us was to treat the left main and the ostial lesion. And so we began to do, to see what happened using the OCT to, we think that the OCT is very useful for, especially for left main bifurcation, not for ostial lesion, but for bifurcation. And with this diameter, which is, we can obtain very good images like this. And we can see here that our main problem will be the distal left main. So we began as usually with a kissing balloon, and the result was quite good, but although we did many inflations with, including non-compliant balloons, we can see here that we cannot open it, at least distal lesion. And that was a real problem. In using the application of this cath lab, which is the stand-based, we can see here, probably, I think that the failure of the other one, the other acute myocardial infarction in 2018 was this one, because the stent was not as fully expanded at the ostial lesion, as we can see here, because there is a calcified plaque there, and fibrotic also, I think. So at this time, we didn't see him with any symptom, no ischemic changes in EKG, but some haziness in the angio. But we can see here a clot in the left main, distal left main, which was treated with 2B38 tiophylline intracoronary. And then we, this is 24 hours later, using a shock wave because of that plaque, calcified plaque. And you can see at the first picture that initially still has that image that does not expanded the stent, but at the final, we could solve it with using all the pulses of the shock wave and use it also at post dilatation. 3.5 12 was the balloon. Then we were working with the Yukon previously. Now we have the Vivo, and we decided to use the strategy to a T-stent with 2 Ds and do again a final kissing balloon. And this is the final result to the left main, although, this is in the spider view. And this is the stent V's, which is the application of the cath lab, and we can see the full expansion of the stents and the other stent, the circumflex. Also, we treated that lateral branch, and this is the final OCT images and the left main. But this is just to we would like to say that OCT is reasonable, an alternative to IBUS image in the distal left main coronary, and it's very useful and for this kind of procedure. But at the final image of LAD, we were talking about short antiplatelet therapy, but I can show you, for example, in the mid LAD, this is a stent, second generation, another one stent, which is not covered by endothelial cells. So I think that in these patients, although I think that the final treatment would be surgery, but till that, I would suggest him, and he's going to continue with his antiplatelet therapy, I think, with these images. So this is my final slide, and I would like to express my thanks to all the committee to this wonderful meeting, and thank you so much again.
Thank you so much, Carlo. Great outcome. Let's ask the panel for 1-2 minutes comment or questions.
Yes.
Let's go, Ruben.
Right. This is an excellent presentation. My question is, Carlos, what do you think that the problem of the patient was the calcified lesion in the ostial LID left main, or do you consider that it was a problem of with the implantation of the stent? Because after the shock wave, the stent was completely open, no?
Yeah, I think that initially was the treatment was not the stent was not fully expanded, and that was a problem. And that one was the problem in 2018 with acute myocardial infarction. I think that the problem was the calcified plaque in the ostial lesion of the LAD, and that was the problem. And we solved it with the shock wave. Yes.
Any additional comment or question?
Alejandro Palacios, quería.
Dr. Castrati, let's Alejandro.
Before leaving. So excellent case and excellent procedure, also excellent result. How often are you using IVL when a stent is in place?
Well, we have right now 4 cases with not, in those cases that the stent was not fully expanded, and we had really good results with the IVL. We use it, the IVL, only in those cases that we cannot fully expand the stent.
So it means that you are using for all stents. You are using it for all stents, but usually you do it before putting a new stent.
Yes, we use, usually we try to use it before, but this time it was off-label because the shockwave is not for these cases, but it's an off-label case.
Yeah, we are using also the same for all the stents, and we are doing the same. Thank you so much. Enjoyed so far, and enjoy the meeting further.
Thank you, Nan. Bye-bye. Good afternoon.
Bye-bye.
Bye-bye. Thank you.
Go ahead, Alejandro.
Yeah, thanks.
Hello, excellent case. I have a question. Carlos, what is the principal reason to select the Yukon stent, anatomical or clinical in this case?
Both cases are anatomical and clinical because of the results with the calcium. This is a standard which has very good results in calcium calcified lesions. So although I think that this is probably also an off-label case because it has stents implanted before, but I would like to say that we try to use this stent because of the trials showing good results in calcified lesions. Yeah, and this is was a good opportunity, and at the same time we received this stent, so we decided to use it.
Okay, thank you, Carlos. Let's move on. Let's move on with Alejandro Álvarez Giorgio. He's Chief Interventional Cardiology at the Interventional Cardiology Hospital Privado del Sur in Bahía Blanca in Argentina. Alejandro is going to also present the case.
Hi, Oscar. How are you? Thank you very much for the presentation. It's a great honor and a big pleasure to be here, to be participating in this meeting. Thank you very much for the invitation to the whole organization. And my complex case, the title is Complex PCI in a severely calcified bifurcation lesion with VIVO-ISAT drug-eluting stent. The clinical case is for a 81-year-old female patient, male patient with cardiac risk factor, hypertension, dyslipidemia, former smoker, diabetes type 2. The patient, about his past history, had an chronic stable angina in functional class 2, but was hospitalized in our hospital because an stable angina. The patient had 2 episodes of angina and dyspnea in functional class 3 and 4 without ECG changes and elevated biomarkers. Echo data Joe was 52% ejection fraction with normal renal function. This is the ECG. The patient had a sinus rhythm, and we can appreciate a right bundle branch block. I was disappointed with this indication because the head of the cardiology department, clinical cardiology department, decided to start studying the patient with a non-invasive coronary angio. And I discussed to him because we knew this is an older patient. We knew his past history with coronary disease, chronic stable angina, and now he was hospitalized because an stable angina. I decided, for me, the best indication was sent directly to the cath lab, but he decided to do the non-invasive coronary CT. The right coronary and circumflex was diseased, but without any significant lesion. This image shows us the left main that there's no any significant lesion. This picture shows us the proximal and middle part of the LAD with diffuse disease when severe calcification, and this is the problem of the patient. The culprit lesion was a severe lesion with severe calcification and diffuse disease at the level of bifurcation between the LAD and the second diagonal. Then, of course, the patient, this is an axial reconstruction of the LAD that we can appreciate in this reconstruction, the diffuse disease, the severe calcification, and a critical point is at the bifurcation with the second diagonal and the extension of the disease to the second diagonal with a calcified plaque. Then, of course, the patient was sent to the cath lab. I choose the radial access. I choose a slender sheet, 6 and 7. And of course, was sent to the cath lab to confirm the diagnostic and to eventually to treat the culprit lesion by angioplasty because he is an 81-year-old patient. This is a 7-frame guiding catheter, but first of all, I try to evaluate the radioscopy image, and as we can appreciate, the diffuse and severe calcification, the proximal and middle part of the LAD, as well the bifurcation. although it's very important to know that angiography is or radioscopy is just not enough to evaluate the severe of calcification, but in this case, yes, this is the angio that show severe disease before bifurcation in the middle part of the AD and the proximal part of the first diagonals. Is not the best projection to show the osteum of the diagonal, but is the best projection, the therapeutic projection. Then we decided to start the treatment of this patient, crossing a run-through flow PO14 wire distal to the LAD and distal another wire distal to the diagonal. First of all, I decided to do predilatation with a small balloon from the LAD to the proximal LAD and the diagonal. And unfortunately, I have not the picture that shows a not well expanded balloon in the middle part of the LAD. Then I decided to do IBUS to evaluate the characteristic of the plaque, the diameter of the vessel, the length of the disease, and the severe and distribution of the calcium. These two images belong to the distal LAD. I don't show the whole video because of time, but these two images belong to the LAD distal to the bifurcation, as we can see an incomplete superficial arc of calcium. And this is a very short video that immediately after the bifurcation that show us a huge amount of plaque immediately at the bifurcation with a deep arch of calcium, incomplete deep arch of calcium, but immediately before the bifurcation, we can appreciate a complete arch, a thick arch, superficial and deep calcium. I measured the area, but now we can see a lot of images that show us the severe calcification, negative remodeling, incomplete and complete thick arch of superficial and deep calcium with shadow, and superficial calcium without no shadow, but complete arch, thick arch of calcium. Then this is a very severe calcified lesion. For that reason, we decided to start the intervention with a device to do plaque modification. In this case, intracorneal lithotripsy. I couldn't cross the IBUS distally to the diagonal. And I helped the lithotripsy intracorneal balloon with an guided with an extension catheter, right, as telescope. I started with the first cycle at the level of bifurcation. Then this is the second cycle of lithotripsy, and this is the third. And in this image, we can appreciate that the distal balloon is not well expanding. Of course, in each cycle, I inflate the balloon up to 4 atmospheres, and when the cycle finished, we continue inflate up to 6. And then, because this is the most critical point of calcification in this bifurcation lesion, I dedicate 4 more cycles. Then I exchange the balloon, advancing the shockwave balloon through the LAD wire. And as we can see, up to 4 atmospheres, the distal part of the balloon is better expanded. After that, I did an angio to realize that there are no any complication, dissection, embolization, perforation, etc. And in this moment, I did IBUS from the diagonal to the LAD. These 2 images belongs to the middle part of the LAD. This is the lesion of the LAD with an incomplete deep arch of calcium. This is the osteal lesion of the diagonal that I did plaque modification with the lithotripsy. But most amazing and important images are these, from these images. Before and after the intracorneal lithotripsy, how lithotripsy works. For example, in this case, in the right before, in the left before, we can appreciate a complete, thick, deep arch of calcium. And in the right, we can appreciate after all the cracking point at the dislodgement of the arch. In this image, the same, before and after, very nice image that show us the cracking point at the dislodgement of the arch. In this image, the same. Before a complete arch and after a dislodgement arch with cracking points. Then, and all these are images after lithotripsy. Then I decided to treat this bifurcation with VivoISAR platform. Was my first time to use this platform. Was amazing. I decided to do a decay crash. Then I advanced my first 3.0 VivoISAR platform to the diagonal. Day I positioned a balloon in the LAD. Then I did angio to reposition the collateral branch stent up to the carina. Then I inflate the stent. After that, I did a stent beast to compare before and after balloon inflation in LAD, to appreciate the crash of this platform. Then I I did an angio to check that there's no any dissection in the diagonal platform. After that, I inflate the balloon in the LAD, and I did a stent beast to appreciate the crash, the mini crash of this stent. Then I recrossed the wire, and I did my first kissing balloon with non-compliant balloon. After that, I did an stent beast to appreciate the result of this kissing balloon, and I did a test with balloon to predict the advancing of the next VivoISAR platform to the LAD. Because the huge mismatch, and was my first case with VivoISAR. In another case, probably we use a very longer platform that we know that the architecture, for example, a 2.5 stent, we can post-dilatate up to 4.5, but it was my first time. Then I decided, because the huge difference between the diameter of the distal LAD and the proximal LAD, and a 3.0 platform, 2.75 platform, VivoISAR platform distally to the bifurcation. After that, I did an angio to check any complication. I retrieved the collateral wire, and I repositioned another VivoISAR platform 3.5 through the bifurcation lesion up to the proximal LAD. Then I did an implantation up to 20 atmospheres. After that, I did a stent beast, and we can appreciate in this image that the distal part of the platform is not well expanded. For that reason, I position guiding by a stent beast and 4.0 balloon to do pot. I did pot, and in this stent beast, we can appreciate a better expansion of the distal part of the stent. And another important thing, the protrusion of the strut and the main vessel to the collateral branch. Then I did another pot more proximally. This is the stent beast to evaluate the morphology. Then I did an angio. I recrossed very easily because the pot to the diagonal branch. And finally, I opened the strut with a 2.0 balloon up to 20 atmospheres. And I did a sequential kissing balloon. And this is the final low pressure kissing balloon with the objective to recenter the carina. I did the stent beast and was happy because the center point of the carina, the position of the carina. After that, with a 4.0 balloon, I did the final pot.
1 minute, Alex.
Yes, I did an stent beast to appreciate the morphology. I crossed the IBUS, and the result was very good. But to finish, I show this short video that allowed me to realize that in the proximal margin of the stent, there's 3 or more strata not well opposed. you can appreciate between the 11 and 2 hours. This is the picture that shows us not well opposed strat. Then for that reason, I use a 4.5 balloon, then stem beads, and final IBUS that show us that finally the strat became well opposed. That it was very important for the results. This is the final angio with a very good result, any complication, and made me happy because doing plaque modification and guiding this procedure by different images allowed me to achieve the better result with this platform in terms of expansion and apposition. I give the patient the better results in terms of middle and long-term outcomes in terms of restenosis, thrombosis, and cardiac events. And we discussed with the clinical cardiologist to give double antiplatelet anti-aggregation to this patient for 1 month, but the department decided to give the anti-aggregation for 6 months. Thank you very much.
Okay, thank you, Alejandro. Any comment? Questions from the panel? Very short because we are running very late.
I would like to make a question to Alejandro.
Yes, go ahead.
I have a question.
Let's go with Alejandro first and then Jorge.
Alejandro, fantastic presentation. I have 2 questions. The first question is, in our country, it's not easy to use IBUS or ACT. How do you select the patient for use image, IBUS or OCT? And the other question is, you can tell us the topics that you use for choice, the different technique in bifurcation lesion?
Very short answer, Alejandro. Very short.
Yes. Yeah, thank you very much for the question. My training was with IBUS. I think IBUS is too much practical. OCT is good, but it's too much practical. And I fight to the endurance in my city to do more IBUS in my procedure, and I achieve. Then for that reason, I can do IBUS in many of my procedure, but always I select to use IBUS in main disease, bifurcation lesion, of course in restenosis, and in multiple and in diabetic patients with multiple vessels disease. And my preferred technique to treat true bifurcation lesion is decay crutch with pot and final pot, but now I modified my technique with the sky inverted technique. That is a new technique that we are studying or investigating. Thank you for your question.
Jorge Baccaro.
Alejandro, excellent presentation. I want to know if you have any way for doing a measurement and about the amount of calcium with VCT or IBUS, just for selecting to use the IVL as a primary tool or as a bailout, because that's because of the cost. So we are choosing like a feeling. I don't know if there is something that we can use more exactly.
Yes, it's very important your question, because as I say today, radioscopy is not enough to evaluate the real severity of the calcium. Then you can realize about the calcium when you predilatate a lesion. But first of all, you must to have all the devices in the cath lab, because many times I'm surprised about when it's severe lesion and the balloon not dilatate or don't cross the lesion. But despite I achieve a good predilatation of the lesion, I do IBUS, and if I see on a deep arch and a complete deep thick arch of calcium or superficial calcium, I try to use, despite the price, the IVL or another device to do plaque modification in terms of gain more lumen, more expansion, and better apposition.
Okay, Thank you, Alejandro. Let's move on with Dr. Andrés Kleiman. He is the Medical Director of Interventional Cardiology Unit in Sanatorio de la Mujer in Rosario, Argentina. And Andrés is going to speak about confronting the calcium with the Yukon.
Hello, hi everyone. Can you hear me?
Yes, perfect.
Yeah.
Okay.
I think the city here in the paper was wrong.
Why?
But are you in Rosario?
Yeah.
Okay, perfect.
Okay. Okay, hi everyone. It's a pleasure to be here with you. Thank you for the invitation. Well, let's go straight to the presentation. It's a 79-year-old Caucasian male. He was admitted at the emergency department for a 30-minute chest pain. He was hypertensive, and on EKG, he has a pacemaker rhythm with a classic left bundle branch block. And on echocardiogram, he had hypokinetic apical anterior wall, and on lab work, some mild impairment of renal function. His past medical record was hypertension, hypercholesterolemia, type 2 diabetes, and of course the permanent pacemaker, some about 20 years ago. Of course, with some sources replacement. About 10 years ago, he had pancreatitis, maybe for kind of medication for his diabetic. It was at that time. And then he had a surgical resection, probably a serious cyst. The problem was that the patient was labeled as a rate disturbance patient rather than an ischemic one. But at this time, he presented with chest pain. On stratification, they asked for a coronary angiogram, so we did that. On the left side of the panel, you can see on this side of the panel, you can see left main without any plaque. And then we see LAD with some stenosis. And you can see there dominant circumflex artery in the cranial position. You see those tight stenosis there, and high amount of calcium over the LAD, but the CERC2. And at this left position, we can see at the early beginning of the obtuse marginal branch, you can see there's another stenosis. And of course, right coronary artery that is non-dominant. So after some discussion, we propose angioplasty by radial access. It's for noting that there is not too much support with this catheter. Maybe at that time I tried to go active support just for giving a better push, and just by going forward with this. And then we cross with a Scion Black guide wire and made some angioplasty first with 1.5 balloon, and then 2.0, and then 2.5. At that time, we had some we had some degree of dissection here. You can see and the large burden of calcium. So we choose to go with IVL, with intravascular lithotripsy with a shockwave catheter, and we did that. But then when we tried to push the stent forward, it had a lack of support, but it was just well by pushing little forward the catheter and with a body wire technique, just putting another guide wire. I just tried to keep it simple and keep it safe. And then the stent, it was a Yukon Chrome. It just advanced perfectly well. We stent the artery distally and with a 3.0 by 24, and then 3.5 by 24, and then a third stent proximally. We had some nice results, and the diagonal branch was well. We have any complication, and then we stent the OM branch of the circumflex. Thank you.
Great case, Andres. Let's ask the panel. Rubén, Jorge, Alejandro, Martin.
Yes.
Yeah.
If someone has a question, go ahead. Okay.
Go ahead.
I have why everybody use the lithotripsy and everybody have forgot the rotablator. Which are the advantage or disadvantage of the shockwave and the rotablator? How do you consider that most of the people use lithotripsy?
I'm not sure why, but I can tell at least my experience. I try to perform lithotripsy when I see a high diffuse high burden of calcium. But for example, if I think that I cannot cross with the balloon catheter, because you know that the IVL hasn't has a very good crossing point, so I just try to go to Rotapro. But my first selection is gonna be IVL in other case.
Okay.
Martin?
Oh yes, Andres answered the question because my question was oriented to the use of rotablator or IVL. So congrats for the case.
Okay.
Yes, perfect. So it's very clear that when we cannot, or very tight lesions, probably rotablator will be the choice, as Andres explained. And in the previous case, when we have the stent, an old stent, IVL is the only option because rotablator is not going to work. This is the two extreme situation. In the middle, and sometimes probably images, and probably nobody knows which is going to be the best. So let's move on. Sorry, we have to move because we are running too late. Let's go with Tomás Cunio. Tomás is an interventional cardiologist and endovascular therapist at San Antonio Plaza in Rosario. And Tomás is going to speak on dealing with the calcified lesions with the Yukon Chrome PC. We are not hearing you, Thomas.
Dr. Thomas, you're on mute.
You hear me now?
Yes.
Yes.
Okay, so sorry. Well, I want to say that it's really a pleasure for me to be here, to be part in this masterclass and to share this clinical case with all my colleagues. You can see my slides right now?
Yes, perfect. Let's go.
Okay. Okay. So the title is Dealing with Calcified Coronary Lesions with SHUCON. This clinical case was performed in Sanatorio Británico of Rosario, Argentina. First of all, while I do not have any conflict of interest to report, then, while the clinical presentation, it was a 70-year-old man. As risk factors, it was hypertension, dyslipidemia, diabetes, and also smoker. It had in 2019 a myocardial infarction with PCI to left circumflex artery with 2 stents. After that, well, he was medicated with dual antiplatelet therapy, also statins and diabetic medication, anti-diabetic medication. Well, the case was that he was admitted to the coronary unit due to STEMI associated with heart failure. In the echocardiography, there appears anterior and inferolateral wall hypokinesia with ejection fraction of 40%. So they started with complete anti-ischemic therapy, also diuretics and nitroglycerin. Then we performed him a coronary angiography, where we can see a total occlusion of proximal coronary artery. That dominance was left dominance. There was a short left main, and then we can see multiple severe lesions and stent restenosis in circumflex artery, and also severe calcified lesions with, most important, severe tortuosity in LAD. I also have here a picture without before injecting the contrast. Well, then I have a video of the coronarography in which, well, we can see the lesions of circumflex arteries and also the severe tortuosity and calcified of LAD. That's a spider view, then also a caudal view. Well, so in this patient, most in these patients that are syntax score probably intermediate, we discuss them in our team. How do we manage him? Well, for calcified lesions, we have always the medical therapy that sometimes is not enough, like in this case. So we can have the possibility of cardiovascular surgery or PCA guided by or facilitated by non-compliance balloon, cutting balloon, atherectomy, or lithotripsy shockwave. Well, this patient, before we decide which conduct we take, he refused cardiovascular surgery, so we advanced with PCI. We decided to make PCI in 2 times. First, we performed PCI to left circumflex artery with 3 drug-eluting stents guided by intravascular ultrasound, but then I will show you the images because if not, it was going to be very long. And after that, a couple of days later, we perform left anterior descending artery PCA. Well, this is the video, a cranial view, right cranial view, so for you to have an idea of the tortuosity and the lesion. Well, these are some photos where you can see the stents of circumflex, and while we cross the lesions with the wire, and we started by radial access, 7 French. We start predilatation with non-compliance high pressure balloons, with small balloons, and then we were increasing the size of them. And after that, well, we made a shock wave, several insufflations guided by IBUS. It was quite hard and tough to advance the shock wave balloon, but well, we could done that. Those are the images after shock wave. In the first 2, we can see the calcium fracture, and in the last one, it appears in mild LAD, a wall hematoma that we can see it with IBUS. Well, after that, we continue predilating the same size, the balloon, and then the stent we were going to implant. And we put in mild LAD 3.0 to 28 millimeters long. sirolimus Shucon stent, and then proximal in overlap, 3.5 to 28 millimeters long stent. This is the final IBUS, where we can see in the first image a stent in 360 grades calcium with a good area. Then the second picture is the stent implantation in where was the wall hematoma. And the last picture is, well, the stent, the distal stent area. This is the final results, the pictures in where we can see, well, the stents in circumflex artery and also in LAD. And here is a video, well, of the final after LAD PCI. Well, after that, to finish some messages, calcified lesions, coronary lesions are a common and underappreciated problem. Vessel calcification may cause impaired stent delivery, stent under expansion, stent malapposition, and stent fracture. Calcium modification, fracture of the calcium with lithotripsy allows us a good stent expansion. We had an excellent stent navigation and symmetric stent expansion with Shucon. And for us, the importance of imaging, IBUS or OCT to optimize results. Well, that's my clinical case. Thank you, everybody.
Thank you, Thomas, and thank you for being on time. Very short question from me. Do you believe that these polymer-free stents are better in calcified lesion, where delamination of the polymer-based stents, which was always suggested, is a limitation for this kind of stents?
Yes, it could be. For me, well, the reality is that I thought it was going to be very tough or difficult to advance this stent, but only with one wire, it was enough. We made really a great predilatation of the lesions and also the lithotripsy, but the navigation of the stent was wonderful, and we have used them in the past in some calcified lesions, and they work properly. So I think we made a good choice. I don't know if I answered.
Thank you. Our panel, Martin, Alejandro. Alejandro's.
Yes,
Jorge.
I would like to congratulate Thomas, because it's an extreme coronary disease, really extreme coronary disease. The patient refused the bypass, but I believe that in my case, I would have refused to treat him. For that reason, congratulations.
Yeah,
Yes.
I agree. As you mentioned, we tried to suggest him, but well, he was denied to bypass surgery. So well, we made first circumflex artery PCA because well, we have to have more support with for then go to the calcified LAD artery lesions.
Very good case.
Okay, let's move on to the last presentation with Dr. Claudio Cigalini, who is the Chief of Interventional Cardiology at Hospital Privado de Rosario in Argentina. And he's going to present the litmus test, Shucon stent for long, diffuse, tortuous, and severely calcified lesion.
Thank you, everyone. Thank you for the invitation. Can you hear me?
Yes, perfect. You have to share a presentation. You didn't click in the presentation there. Yeah.
Okay. Sorry. It's a pleasure for me to be here sharing cases with you. The present case is about a 60-year-old male with many cardiovascular risk factors, with diabetes, peripheral vascular disease, chronic kidney disease, and he was in treatment by hemodialysis. He has a previous PCI with implantation of DES at the middle LAD because of acute coronary syndrome. And now he was present with a high-grade angina and perfusion myocardial perfusion with anterior ischemia, severe anterior ischemia. This is the angiogram where we can see he has no lesions at the right coronary artery. So we are showing the target lesion of the case, that this is the LAD. We have a very diffuse disease
severely calcified and some tortuosity with M configuration. You can see here and here. No left main lesion. Because it was a very long and tight lesion, we decided to treat this lesion with a rotablator, and we discharged the use of IVL in this case. Here there was some restenosis and the distal stent with some subexpansion. We went first with the 1.5 burr, and after that we did the same with a 1.5 burr. But it wasn't enough, so we had to go. We need to go to the high pressure balloon of more than 20 atmospheres in many segments. So after that we could cross. Before that we couldn't cross with the IBUS catheter. Now you can see the image after a rotablator and predilatation at high pressure. You can see the superficial calcium and some areas of fractures. We exchanged the rotawire by extra support wire. But in spite of that, we had some difficulty to advance the first stent. So we use a guide extension, a guide seal extension with a deep intubation. So we can cross the lesion, and we implanted the first stent, the 2.5 by 28 Yukon chrome stent, covering almost all the longitude of the previous implanted stent. After that, we went with the second Yukon stent, 30 by 32 stent. Here we can notice the severe calcification and the tortuosity of the LAD. And there was some sub-expansion at the proximal part of the stent, so we post-delayed this stent at high pressure before to implant the last stent at the proximal part of the LAD. Here we choose a 3.5 by 22 millimeters. Here we have the final IBUS result and the angiographic result. That was satisfactory for us. The patient has 6 months of follow-up. She's angina-free with a functional test negative. He was treated by prasugrel and aspirin after the procedure. Thank you very much.
Okay, great case, Claudio. Thank you for the time. So let me ask you again to the panelists, Ruben, Jorge, Martin. From my side, I would say that this is a very long lesion, and this is a typical case that you have to use 2 burrs, and sometimes in the proximal part of the vessel where it's too big, you only have, fracture or polish the subintimal calcium, and in many cases you have to use an additional device like a very high pressure balloon, or even though a cutting balloon for this situation, which becomes in a very expensive procedure. But anyway, with a high pressure balloon, you get a very good outcome, and then the extend did very well. So yes. Any additional comment? Well, if not, I think we have to close the session. First, I would like to thank Translumina for the invitation and George Macrae for the invitation to me to moderate this session. It was an honor to have Professor Adnan Castrati, to have this such distinguished panel and all the speakers. With all of them, we have learned that the CEN did very well in a very challenging cases that you have showed to us today. And I think Dr. Castrati showed that the late outcomes, especially for diabetic patients, are going to be okay. So you might feel okay with your cases because the follow-up would be also okay. So with anything else to say, I'd like to thank you, everybody. Thank you, the audience, and say bye. Have a good day, and enjoy the rest of the day, the week, and the World Championship. Thank you. Bye-bye.
Thank you.
Bye-bye.
Thank you. Bye.
Thank you, everyone. Bye-bye.